Hello, everyone. Welcome back to another episode of Reversing Hashimoto's. I am your show host, Dr. Anshul Gupta, a world's expert in Hashimoto's disease. I help people reverse their Hashimoto's through functional medicine plans. And I'm really excited for our today's guest because after a long time, we are discussing all the hormones in detail. There's so many hormones, and thyroid being just one hormone in the body, and majority of the people with Hashimoto's disease have an imbalance in multiple hormones. So today's guest is an expert in hormonal health, and we are going to talk about different dysfunctions of hormones and how to get rid of them. So, but let me introduce our guest first before we move forward into this great discussion. So, Betty Murray is a women's health advocate, nutrition expert, PhD researcher, certified functional medicine practitioner, author, and speaker. Betty helps women over 50 harness their hormones to lose weight, optimize sleep, restore energy, and thrive. During her research, during her research for her PhD, Betty made several key discoveries that led to hormone and metabolic imbalances that plague women over 40. Restoring balance to these key metabolic and hormone pathways is the basis for her menopause metabolism mastery program. This program has helped her and hundreds of women lose weight quickly, improve hormonal balance, reduce hot flashes, restore sleep, and turn up their energy without living on a diet of deprivation. She hosts the Menopause Mastery podcast and is a founder and CEO of Living Well Dallas Functional Medicine Center and Minerva, a femtech startup and national women's telemedicine company delivering bioidentical hormones treatment through virtual telemedicine. She is featured writer for Brain Magazine, and she has been featured in Grazia Magazine. She is a frequently featured nutrition expert on Fox News, CW33, NBC, and CBS. Betty, welcome over here.
Thank you, Dr. Anshul, for having me. I'm excited to be here.
Absolutely. That is a great, great resume you have out there. You have done so much. We have collaborated before. You have come on a show before, sharing so much great information. And it just keeps on that, we can keep talking about this topic that you are talking about like forever and ever. And there is so much new research and new information keep coming. So specifically, like we want to talk about female hormones, thyroid hormones, and also maybe touch a little bit about the BHRT, which is the hormone replacement therapy in the end also. But I just want to kind of throw or start with this question about, there are so many different hormones. And so how are all of these hormones interconnected with each other, especially insulin, like hormonal issues of thyroid and menopause? Tell us like, are they all connected or not?
So the way to think about hormones are that our hormones are like a symphony, right? So we have two controllers in the brain. We have the hypothalamus. Think of that as the director of the show. So that the hypothalamus sets the tone, sets the, what do we want the show to feel like? The conductor is the pituitary. So the conductor is really the one that's talking to the different parts of the orchestra. So the percussion section, the wind section, the brass section. And so if you think about our hormones, think of each category of hormone as this separate section. For instance, the adrenals, I like to call them the percussion, right? The adrenals are what handle your stress response. So they set the tone and the speed. And then you've got your thyroid, which is your wind section. You've got your sex hormones, which are the brass section. And ultimately, it's the pituitary and the hypothalamus that is instructing these hormones to do different things at different times in response to what's happening. So the hypothalamus gets its direction from everything happening in your body. So all the chemicals that we make, the experiences that we have, the thoughts that we have, our olfactory and our senses, like what we see, what we smell. And it's making decisions on how things are going to go based on that. So the challenge is we silo medicine in a way that, you've got somebody that is an endocrinologist, let's say, and all they're doing is sort of narrow attention. And even in endocrinology, they often focus on one area, let's say, blood sugar control and diabetes. But the reality is that they all play together. So if I have been stressed out for 2 decades, and, I'd like to say, I'd like to meet the woman that's at my age that doesn't have at least a good 1 or 2 decades, under her belt of stress, right? And let's say I'm very, very stressed out, and I also maybe, not getting enough sleep and I'm in perimenopause, what essentially is happening is your entire orchestra thinks that they're playing a waltz, but the percussion section started playing jazz. And then what happens is all the other hormones are going to try and bring harmony. So they're going to try and rebalance to the most dominant scenario that your body's trying to handle. And I like to argue that I think stress is the dominant one. That one threatens our survival. And so, so when we start looking at whether we're trying to fix a thyroid problem or we're trying to fix a perimenopause and menopausal problem, we really can't look at them individually. We have to look at the entire orchestra. Because there may be more than one thing going on. And in most cases, there is. And that was my personal story. My personal story is I had a lot of hormone imbalances going on. And when I was going through my 40s, I'm almost 55 right now. It was like, okay, we're going to work on the thyroid. No, it's not that. Okay, we're going to work on your progesterone. No, it's not that. Okay, we're going to work on your testosterone. And it wasn't really taking a step back and looking at this as a bigger picture item. And so I think for a lot of particularly women, they're pretty sure they've got thyroid problems. Maybe they've been diagnosed with Hashimoto's. And I would say, yes, even if they're not diagnosed and their labs look normal, you probably do have a thyroid problem, but that may not be the only problem. And so we have to remember that they all play together. And even things like blood sugar control, your insulin is going to be heavily regulated and interplaying with your stress chemistry and even the sex hormones. And so you have to sort of look at the whole picture and be able to pull it apart.
Absolutely. I think that was a very, very detailed explanation about how all the hormones are connected. And I think that's where a lot of practitioners or even patients do not understand it, because they're thinking, okay, it's just one hormone. Get me external hormone of that and that will rebalance it. Everything will be okay. But what I'm hearing over here is that it's a whole symphony of things and you have to work on each and every piece of it, not just one of them, right?
Yes.
And I think,
Absolutely.
you went through some hormonal struggles and that's what you also did for you. Like you work on the whole body approach, rebalancing all the hormones, then only you saw the results.
Yes, it's interesting because I came to functional medicine originally because of a colitis diagnosis in my 30s. And I was able to get my digestive disorder under control, felt better, started my private practice. But by the time I hit about 39, I started having what looked like thyroid issues and hormonal issues. I had previously been into bodybuilding and weight training, so I understood how to manipulate my body composition. I started gaining weight, and hindsight's always great. So I was diagnosed with low thyroid function, but before that I'd had a mercury amalgam removed, in my mid 30s before I knew about biological dentistry, but slow, oddly enough, about 6 months later, it was like my thyroid took a nosedive. So, I see one of my functional medicine docs and they say, okay, your thyroid is low function. Let's start thyroid. Well, I got put on thyroid medication and none of my symptoms changed. My hair kept falling out. I kept gaining weight. I used to joke that I looked like the Budweiser lizards because I had very swollen, occipital, swelling around my eyes. And then we started changing doses. We would go to all these different doses. We did compounded T3, T4. We did everything. Nature thyroid, NP thyroid, Armor. And no matter what dose and no matter what combination I went on, the symptoms I was experiencing didn't really get better. My energy maybe got a little bit better, but all the things that most women are going to be upset about, the weight gain, the, skin texture, the hair loss, all of that was still there. So then we kind of moved on. Oh, you must be in your 40s. I was getting some acne on my chin and my cheeks. It's like, okay, that's a sign of perimenopause. So it was, okay, put you on progesterone because I had a lot of estrogen. I was kind of estrogen dominant. And I was put on that. My sleep got maybe slightly better. And then it just, it was this kind of constant ping ponging between hormones, knowing that I was in my 40s and I had kind of high estrogen relative to everything else because I was already in perimenopause. And no matter what I did, I could move the needle a little bit on a couple symptoms, but I couldn't necessarily get particularly the weight off because I gained about 35 pounds in less than a year. When all of this sort of hit, and it was this kind of early, 39 to 40 sort of bang. And, and so I basically existed like that until I was about 48, trying different hormones. I remember I was put on testosterone, a pellet, and it made me feel great. And I was like, I had some energy, but I gained 10 pounds in a month and a half, because people forget testosterone is an anabolic hormone, right? Particularly in women. And so I was like, oh my God, I don't want to do that again. I'm like, okay, stop that. And what's going on, because all of these kind of play together. And by about 48, I started my PhD research. I sort of ferreted this stuff out. And by end of 49, I was able to get all the weight off. I got it off in about, 12 weeks, about 12 to 16 weeks. I've had it off the entire time because I now know how my metabolism is really working with my hormones. And I'm able to manipulate both. So I'm not symptomatic. And I'm also able to maintain healthy body weight, because to be honest, Anshul, I was so embarrassed of I'm a nutrition professional, like multi-credentialed. And I'm like, okay, I don't want to talk about weight loss in my 40s, because I was like, obviously I can't figure out what's going on here. Right. Which is a tough place to be in, really tough place to be in. So, so not only do I understand autoimmune diseases intimately, but now I understand the struggle of women, because I've been there. And I also understand what's really happening underlying all of those kind of mechanisms. And it is frustrating for women.
Absolutely. I think a lot of women who are listening over here will absolutely relate to this story, because most people who are working with us are struggling with weight. They don't know what to do. They're trying different diets. They have been put on BHRT or different hormones, say that is going to lose their weight. They have literally tried exercising to the point that they are passing out, and they don't know their gym trainers what else to do. And they're still tired. They're still brain foggy. They're still not able to lose weight. So absolutely, I think a lot of people will relate to that. Now, this question obviously arises, is it just the, passing of phase that the women are going through because of hormonal dysfunction, which they have been told that, oh, well, it is a menopause, or maybe you are entering into early perimenopause. That's the reason all of these symptoms, or there is much more to it?
So I think there's a couple things. I think it's multifaceted. I think it's a little bit of both. So the truth is, in 1900, the average woman's lifespan was 57 years.
Wow.
Right. So I only have 2 more to go. So if we went through, so if you think about that, if you went through menopause around 52, did it really matter that much about your symptoms, honestly? Well, now we're living 35, 40 years past that date. And, and so now we're embarking on a new environment. So there's a bunch of things that happen when we go through perimenopause that lead to metabolic dysfunction. So statistically, the average woman going through menopause will pick up 10 to 15% of her body weight. So if you're 150 pounds, that's 15 pounds on the low end. I'm 5'3". You put 5-10 pounds on me, I have to change clothes, because of where it goes, So there, a couple things happen, particularly as estrogen and progesterone levels decline. First thing is, we know that women get a lot more visceral fat increase, right? So that's the fat under the muscle in the abdomen around your organs. And that is, you can't diet that off. It does not move for caloric deficit. So for those of you that are listening to a trainer and he's like, you just got to burn off more and you got to watch your macros. Visceral fat in women in perimenopause and menopause does not move with caloric restriction. The reason why we get it is because we have an increase in the inflammation, which increases fat storage, and we have a decrease in metabolic activity in the fat cells, and then every single cell in our body decreases its function because estrogen actually influences our powerhouses, the mitochondria. And so, women have this uphill battle. The body starts to shift and starts putting fat around the middle, which makes us more insulin resistant, which then makes us store more fat. And then if you add stress on top of that, we've got the cortisol driving more insulin. It's this sort of vicious loop. And so I think we have to look at it and understand that what worked when we were 25, 35 isn't probably going to work today. We have to shift how we do it. But it doesn't mean we have to starve ourselves either. I mean, coming from a bodybuilding background where, you go to the cutting phase and you're eating 1,300 calories a day and you're lifting heavy 6 days a week, and then you're starting to dehydrate, all that stupid stuff that you do for bodybuilding. I was like, I will never live like that again, and I think most women, we're here and we're like, I don't want to live like that, so it's just, we have to change our tactics.
So that's a very common question that I get, with people who are working with us also. Well, at 25, or as you said, at 20, I will just do a diet for a few days and I will shed like this extra pound. And now I have been dieting for a year or so and still cannot move it. So all those people, you have the answer. So your body is different at 20 or 25. Things which are happening in your body was different. Now, at probably once you cross 40s, then the things are different. So you have to approach the weight loss strategy in a different way. So tell us some strategies like where people can do, because you said obviously like, exercising too much or even going on a crash diet is not going to work. So first of all, maybe like shedding a little bit more light on what is excessive exercising and also what is crash dieting. And then also what they can do that will help them to lose weight or improve their energy or brain fog this time of the year.
Right. So some of us genetically are wired to be more endurance athletes or to be more weight bearing athletes. Like I am definitely wired genetically to lift heavy things, is what I say. I'm just, love it or hate it. That's what I'm wired to do. And most women would fall into that category, at least the ones I have tested over the last 12 years with their genetics. So when we look at exercise, we have to understand that it's not just a way to pay for what we did the day before, right? As a form of punishment. Exercise not only helps us cardiovascular health with heart rate variability and recovery and oxygen and all those other things, blood flow, but it also builds muscle. The most important thing that women can do is double down on muscle building activity. We rapidly lose muscle as we enter into perimenopause, and we lose about 1 to 2% a year, right? So if we don't do active things, the more muscle you lose, the more bone you lose, and the more likely you are to have early mortality, right? So the stats are more muscle, the longer you live. So what that means is we need to spend more time doing weight bearing exercise and less time doing things like intense cardio. And that may also include high intensity interval training that is long in duration. I meet a lot of women who are doing things. I bring these people up all the time and I'm like, I'm sure they're going to be mad at me. Orange Theory, right? Orange Theory is huge. But Orange Theory overtrains people. Right. They took an idea of post exercise oxygen debt, which has its greatest effect at 15 minutes of total exercise and has diminishing returns. And they take that and they go, okay, you got to come to this 45-minute class. And then they make you compete. So most of my highly competitive type A professional women will get in there and overcompete, which just raises their stress chemistry, raises their cortisol, and actually becomes counterproductive. I'm not saying you can't do it, but you shouldn't do it 4 times a week because you can't burn it off. That's the thing, is you can't just burn it off. But weight-bearing exercise gives a different instruction. And then movement is really important, but it doesn't have to be at a cardio intensity. So zone 2, where you're in that kind of 120 to 134 heart rate, helps from a heart rate standpoint. So exercise and retooling the exercise is important. And I'm not an exercise physiologist, but I obviously have been around the arena for a long time. The other thing that I think absolutely has to be doubled down on is the sleep. You cannot fix hormone problems, and particularly adrenal and thyroid problems, getting 5 hours a night or less. You just can't. So you have to double down and fix it. And that might mean, retooling your schedule, staying off electronic devices, getting early morning sunlight to help with circadian rhythm, all the way to finding out if you have sleep apnea or upper airway resistance. Women that have sleep issues like that have a much lower threshold before it starts causing metabolic problems. So you don't have to snore like a freight train to have a problem. But that will drive extraordinary insulin resistance and weight gain. And then, the other side of it is also looking at what hormones need to be replaced and where and when and how. I'm of the mindset, yes, menopause is a transition. 100% of us go through it. 87% are symptomatic for, on average, up to 8 years. But the symptoms aren't the only thing, right? We've been told that, if you need hormones, it's, particularly sex hormones, it's solely to control your vasomotor, which is your hot flash and night sweats, but that's it. And that's very, very far from the truth. And I think when you can get all the hormones balanced, you also improve those things that are happening behind the scenes metabolically that just make everything work better.
Absolutely. I think those are so great, important points that, again, looking at the whole complete picture and understanding that it's a more complex problem than just kind of giving a particular hormone or doing a particular exercise, looking at all the underlying dysfunctions in your body. And that's what particularly we do in our practice too. That we want to make sure that the whole body as a whole is in balance or in sync, as you said. Otherwise, just kind of pulling one thread, you might get some benefit for a very short amount of time, but in the long run, those benefits are not sustained. So I'm glad that you brought up this whole picture of working on lifestyle and then obviously working on the hormones and the supplements and things. So in that aspects, I would like to talk more about this BHRT or hormone replacement therapies, because it's such a hot topic, right, which has been there for a decade now. First we were like, okay, well, everybody should get BHRT, then we're of the point that okay, nobody should get it, and now again we are more pro BHRT. But then different forms of BHRT is coming up, right? Like we have this topicals, we have oral, and then we have these pellet therapies and stuff. So I would like to kind of ask you a few questions around that. So first of all, for the BHRT, what do you think? Should every woman go on BHRT, or there is any specific kind of woman that should be going on BHRT?
Yeah, so BHRT, I'm just going to give a little bit of background in case somebody that's listening isn't familiar with it. Up until 2002, BHRT, or actually HRT, in the form of what they call conjugated equine estrogen, which is an oral estrogen, and usually a progesterone that has been micronized in a capsule, was standard of practice, right? So your grandmother probably had it. And it was the Women's Health Initiative, and it was a subset of the researchers that had an agenda to prove that hormone replacement was unsafe. And so they basically, before this paper ever even went through peer review, and as a PhD, I can tell you this is a brutal process, brutal. And nothing should have been released until after peer review, because it would have been the statistics would have had to been rerun because they were using the wrong statistical measures. So they released this really inflammatory language. The media picked it up and ran with it. And overnight, hundreds and thousands, millions of women were taken off of hormones. And we were told it was going to kill us. So what happened in the last 20 years? So there's several landmark studies that have come out. There was one done by Dr. Mosconi's group looking at 6 million women and the risk for dementia, looking at hormone replacement and no hormone replacement. And that one was published earlier this year. And they found that a 34% decreased risk in dementia if you replaced estrogen, and particularly earlier in the process, right? And that included the Women's Health Initiative data. Now, flash forward to May of this year, the Women's Health Initiative data was statistically analyzed by the team, and they republished. So on follow-up at 18 years and now at 22 years, all of the assertions they made in that paper were wrong, and they retracted all of it. Now, have we seen a bunch of headlines about that? Absolutely not. Absolutely not. It's a war on women's health. Now, there was also a study that just came out in April that looked at Medicare records. And this one I really love. So these are women 65 and above, and they looked at mortality between 2007 and 2018. And they had 10 million women. 10 million. And they compared those who never went on hormones, those who went on hormones, both estrogen and progesterone, compared oral against topical. And then they compared the women that started it but stopped it very, very quickly, because that became kind of the next thing. Oh, just on them for a little time. And they looked at all-cause mortality. And what they found was hormone replacement kept in longer reduced the risk for deep vein thrombosis, stroke, heart attack, lung cancer, breast cancer, colon cancer, dementia, osteoporosis. I would throw that one in there too, right? So, and the women that didn't take anything, more mortality, right? The women that took a little bit didn't really get the benefit. When they compared the group between oral and topical, there is a slight increased risk with oral estrogens for clotting risk. If somebody has a clotting disease risk, oral estrogens, because they pass through the liver before we actually use them, they make a bunch of metabolites that are hard on the body that can increase clotting risk. Well, if you remove oral and just do topical, all of that risk is mitigated, right? So even somebody who might have a genetic clotting risk could look at topical hormones. So these are game changer studies. These aren't small studies. There was another one that came out of, I believe, Denmark earlier this year. So ultimately what it means is that hormones are on the table. I'm of the argument for bioidentical, which means that it looks exactly like your hormone. It is the exact same key. Synthetic hormones are kind of like a skeleton key that's a little bit different, which means they operate differently in the body. And I think we have more elegant ways to do it today. And then it becomes, what type of topical do you use? Or do you use something like a pellet?
Yeah, so tell us more about this, because we have these new technology of using pellets versus topical, and obviously, like oral has always been there. So differences, pluses and minuses of topical versus pellets. And first, like, tell us what are exactly pellets?
Yeah. So as a disclaimer, I'm the world's worst about using myself as a guinea pig. So I've had every form of hormone replacement, right? I've used every one, used different compounding pharmacies, different versions. I've had every company's pellet in my butt. So I've actually used BioT, Avexapel, and Sotapelli, who are the main manufacturers in the US. Mostly because I wanted to see what was happening, right? I'm a scientist. I can't help myself. So I use myself. So pellets are bioidentical hormones that are made into a very small pellet. So like the top of a little Bic pen where you write, they're tiny and they're compressed heavily. And then they make a small, tiny incision kind of in the flank, like the upper part of your butt. And they insert it right underneath, kind of in between the subcutaneous fat and the muscle. They let it encapsulate, and then it slowly dissolves over time. So, a lot of people like the pellets because you do it every 3 to 4 months as a female. So you don't have to remember to do it every day. They often will do estrogen and testosterone that way. Progesterone is almost always given orally. Some conventional docs will also do a progesterone IUD. You want to make sure that if you're doing hormone replacement that you're on progesterone, particularly if you have a uterus. Progesterone is also really important for hundreds of other body functions. So oral progesterone is protective, to counterbalance your estrogen. So I need them to be balanced like they were when I was 30, right? So oral progesterone always. And then when you look at estrogen topical, so estrogen topical can be done in a cream, it can be done in an oil, and then it's all about the application, and it's either done usually in a patch, right? So the patch is going to be a bioidentical estradiol, and then the creams are often either a bi-est combination, which is estradiol and estriol, which is a weaker estrogen, or straight estradiol. Some people do better on different ones. So we literally in my clinic use every form, because depending on the person, they might be like, you know what, the two pellets or 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 I believe that we have to look at each person individually, and we tend to start low and go slow and help the patient vary until we figure out where they need to go, and we do test along the way. I think most women are candidates for hormone, right? I think every woman's an individual, and we have to look at their individual health history and their individual, concerns and health up to this point to figure out what would be the right avenue.
So, but tell us a little bit more about, like, what are the positives about pellets, why, or what are the positives about the topicals things? Because, each and every comes with a little bit of a risk or downside to it, and definitely like some pluses. So tell us about that.
Yeah. So pellet therapy, this is my opinion. So here's the beautiful thing. I'm a PhD. I don't prescribe. I have prescribers that work for me, but I'm the one that digs through the research. I believe that, so all of the pellet companies have a calculator that helps you calculate what somebody needs. I think that they heavily promote a testosterone level that's often too high, right? Because it's all about getting into a balance. We don't necessarily want it higher is not better. Because for women, if we get too much testosterone, we can have things like hair loss, chin hair growth, which we're already having in menopause anyway. So you don't want to amplify that. So I think it's important to work with your practitioner to make sure that you're managing that dose and you're watching it, because it can climb over time. So I think in some ways the pellets, because they are slow dissolving, they are very dependent on somebody's athletic activity, right? If you're sedentary, you're going to metabolize it much more slowly than somebody who isn't, and everybody's a little different. And so we believe in testing, not guessing, and not just going off symptoms. Because again, you may not be symptomatic, but you may not be getting a dose that's therapeutic either. And then when you come to the creams, some people don't have great absorption of the creams, despite doing fairly heavy doses. I think a lot of times that also depends on the quality of the compounding pharmacy. We are very particular about where we send our prescriptions, because that's the argument against BHRT. If you talk to a conventional doctor, they'll go, oh, there's too much variability. And I'm like, no, there are some really good pharmacies out there that are very standardized that we know work well. And again, you could do the patch. And I'd say the patch, some people love. You usually put it on twice a week. But if you have an adhesive allergy, you can't wear the patch. So I think it's one of those things that people just have to know that it might take a little bit of playing around with the different versions to find the right combo. And then once you've got it, it's usually pretty easy to kind of manage after that.
Absolutely. The other thing, which is again, a couple of patients have come to see me is that, some of their BHRT practitioners say that, like their estrogen or testosterone hormones needs to be so high that they start menstruating again. Like, what are your thoughts about it? Please share about that.
Yes. And it's interesting because I've had this conversation with a friend who's a longtime, practitioner in this world. And if you think about it physiologically, like, okay, you're taking yourself back to your 30s where your body thinks now that it can ovulate, and that's back to where you want to go. We don't have literature that says that, right? So I'm very much like, if the research doesn't say this, we either need to research it or we need to figure out a way to figure it out. And we don't have enough data around women menstruating at 65, that have stopped and started to say that's the right way to go. Personally, the only thing I could look forward to about menopause was no more periods. Like, I want to have my hormones balanced so I have the youth giving effects of it and the anti-aging and the disease prevention effects, but I don't want to go through that roller coaster anymore. So personally, we don't do that. We get it to a therapeutic level and also a level that the patient feels good, right?
Absolutely.
We care that, but I have no interest in making people go back to having a period.
Same here. No, that's what I also believe in, that we don't have absolutely any research studies supporting that, that the females should continue to menstruate, and that is a healthier way of going through aging. So I totally believe that hormones have a role to play, but I think, like we are still learning, and people like you who have mastered the art of bioidentical hormones and who is the right person and how to do it safely is still, I think, is a very important thing that people should be aware of.
Yeah, no, I agree.
Great. I think we can keep going on with this discussion for a whole day, as we said, but I think our time is coming to the end. But I think you have this wonderful quiz where people can take, which is a free quiz, and they can know much more about their hormones. So please share more information about that.
Yeah, so the quiz, I guess, which will probably be in the show notes. The quiz is it takes about 2 minutes to do, set of questions to help you identify what's your major hormone imbalance. Again, if you're above 40, you probably have more than one. Let's just go ahead and own that. This is going to help you figure out your dominant, hormone imbalance and how it might be contributing to weight gain, fatigue, those kind of things. And when you get done with it, you'll get your own personalized report that'll kind of help you understand what's really happening.
That is awesome. Please, guys, the link will be in the description. Go and take the quiz. It's free. And you get so much information about your hormonal imbalances so that you know exactly why you're feeling the way and what is happening inside the body. Because unless you know, how are you going to take action to fix it? So thank you for providing this quiz. Any other parting words you have for our listeners over here?
I would say if you're feeling really frustrated with your body, because most women will say, gosh, it's the weight. If the weight would go away, everything's perfect, right? everything would be great. I'll do the new thing I want to do. I'll live my life will be fantastic. The weight is not the problem. The weight is a side effect of the problem. It is not the problem. We've got to get to what the problem really is, and the weight will come off when the body is healthy. That's the important part. And unfortunately, conventional medicine gets it wrong. And it's because they have no answer for it. And so if you're feeling frustrated, know that your body thinks it's protecting you. It doesn't realize you don't like what you see.
Absolutely. I think that is so, so much important. I think we are looking after numbers so closely that a lot of women, okay, well, this is the number I want to be at. I said, like, how did you come up with this number? Well, when I was 18, this is the number, like, of weight I was, or in my 20s. So I tell people is that your body changes, so if your body is liking this current weight, just be with it. And let's work on the other things. So I'm glad that you and me are on the same page on this aspect, and we are promoting a healthier body and beautiful body, and obviously, like, living a longer, healthier life. So thank you for doing that. Thank you again for coming on the show. Thank you. Thank you so much, people. We are going to post again social media links where Betty is available. So please check out her content, especially if you want to learn more about the hormones. Thank you, Betty, again coming for the show.
Thank you for having me. Have a great day.
Okay. All right, guys. Take care then. Bye-bye.